So Michel has presented a lot of morphology of the vessels in the case of pathologies, and I will present how we do image blood flow in them by computational imaging that we call laser Doppler holography. So it's, I get messages as well, so 1 second. Okay. So the system that we use is actually very simple. It consists of an interferometer with near-infrared laser that we focus just in front of the eye, and the light is extended into the back of the eye in the retina in white field, and then we collect the few photons that come back from the back of the eye with a camera that is set as a given defocus distance from the natural image plane that we have through a simple imaging lens. And so we record a diffracted optical wave field that we combine, that we mix with a separate reference with this interferometer. So you have the laser diode that is split here, and the photons that come back from the eye are mixed with this reference, and we record the interference pattern from all of that with a high-speed camera, typically more than 60 kilohertz, and a low-speed camera, video rate, which can go up to 1 or a few kilohertz. And from there, all we have to do is computations to create our images of the eye fundus. So let me break this down in 2 very simple steps. The first one, so we take the interferograms and make a reconstruction through wave propagation, just wave field propagation. And then we analyze at each pixel of the image. Here you can see the remnants of something. Well, if we compute the time fluctuations at each pixel, we get a power Doppler image like here with a good temporal resolution. We can go below that nowadays. So here is what it looks like in a healthy volunteer. So you see the arterial vessels, the arteries of the retina, and the veins, all the branches in the retina as well. And you also see beyond the retinal pigment epithelium some large vessels over here, which are basically vessels of the choroid. I will speak about them a bit later. Okay, it works with pretty much everybody that we've been able to have. It's typically hundreds of patients right now, and it works even in cases of opacities in the anterior segment. So we're very happy and proud of all that. And the kind of contrast that we get from these images is basically blood flow. So we have these wonderful pulse waves. For instance, in a retinal artery, it has this steep increase during the systole, and then it decreases slowly during the diastole. And you even have this rebound, this bounce, which is a dichrotic notch and indicates a very good elasticity that we see in very healthy and young volunteers. You also see in this particular example some kind of crosstalk between the artery here and vein here. And during the systolic peak, in the vein, you have an anti-peak, if you will. So all of that has been made possible because we've been building a robust statistical filtering method of bulk motion and parasitic reflections by singular value decomposition. And the issue we had to solve is this case, when we have an overlap between the Doppler response of the flow in the tiny vessels, typically small flows, and small Doppler, if you will, and the bulk motion and parasitic reflections that are typically at low frequencies. Okay, so if you do a diagonalization of your images through time, in addition to the Fourier analysis, you can go beyond Fourier analysis here. This is the top row, and remove parasitic reflections, bulk motion, and camera jitter even, and get those beautiful images down there of small flows. Another thing that we've been able to add to that is digital rephasing And one of the important things that we did in digital rephasing is aberration correction here that I present, which is simply taken from the work of Rainer Leitgeb that has been used for OCT. So let me try to briefly describe it. So we record here in the sensor plane this interferogram, and then we make a computation to get to the image plane. And then we can also propagate our wave field either in the reciprocal plane of the image or the pupil plane, if you will. And then we can divide this pupil plane into small chunks. And in each chunk, we can make a back propagation of the image and get this image. And if we calculate and measure the relative displacement of all the tiny images with respect to another one of them, reference one, basically we get the form of the wavefront, optical wavefront in this plane, which is very valuable because if we project this distortion of the wave field onto a set of Wernicke polynomials, it will enable us with great acuity to basically perform adaptive optics. So we take the complex conjugate of this lens, and so we start with an image that is blurred, but this is the best focus. It's because it's a patient with astigmatism, strong astigmatism in this case. So then we compute the smaller images, and then we compare this one to all the other ones and get those cross-correlation functions where we seek the displacement of the maximum, then project onto this, for instance, 2 rows of lenses. And so we compute the lens that was there, and we improve the quality of the image, especially for small vessels. So SVD, singular value decomposition, and rephasing enables us to see low flows in microvessels, which is here you can see what happens from the left to the right without and with those SVD and adaptive optics, and here with. And you see it's not very important for high flows, typically. You don't see much difference, but the difference is important for small flows and small vessels near in the vicinity of the papilla. Okay. Anyways, ophthalmologists want everything, and it's not enough to have high resolution. They want a larger field of view, which is a different problem. So to tackle that, what we did is to change a little bit the instrument, increase the power of the lens that is used for imaging, and then we have increased a bit the field of view. We have created a few color images, indicators of blood flow that I will present briefly here. So basically, the larger the local flow, the larger the Doppler distribution. So if we make a low frequency power Doppler and a high frequency power Doppler, we can encode in an image low and high flows here in red. Another indicator would be to record an image, a power Doppler image during systole and then during diastole, and then we naturally reveal retinal arteries and veins. We can also make use of the asymmetry of the power Doppler spectrum, which occurs naturally in places where you can find the lumen of perpendicular arteries and veins, typically the central artery and vein. And then you compute positive Doppler shifts, negative Doppler shifts, and you see a difference that you encode in red and blue respectively, where you can actually measure the speed of your blood flow. And Leo Pouillot will speak about that later today. Another indicator would be the modulation, local modulation depth of the pulse wave that you see, and you divide it by the systolic peak, and you get the resistivity index that I will speak about a little bit in here. Okay, so let's have a look at what healthy volunteer look like. So basically, we have all the indicators that I talked about, and I would like you to have a look at this triangular shape for the pulse wave. Okay, so healthy volunteer, no problem. And here, the resistivity index in the branches of the retinal arteries. Okay, so it's typically 0.5. Okay, again, the same in another person from the control group. Okay, so one of the questions here are what are the clinical uses of this technology? Of course, it's retinal and choroidal flow visualization. And the LDH, laser Doppler holography, compares very, very well without any contrast agent to ICG and also OCT, with the added value that we can spot directly at first glance the choroidal arteries in the color image. They appear in red because the flows are typically much higher than in veins, and so you get this discoloration. Okay, it works with pretty much everybody. Now let's move on to pathological cases, and I have selected a few ones. First of all, central retinal vein occlusion, where, have a look at the resistive index here. So the central retinal vein is occluded over here, and you have a consequence on the resistivity index. So the hemodynamics is changed with respect to the control group. This index is twice higher than normal. Okay, so the modulation depth is more important. And you can see that with respect to the control eye, which has a resistivity index, which is much lower in the same patient. Okay, in the case of retinal vein occlusion, you can also see the development of retinal shunts, venous shunts that go into the choroid here, and their pulsatility. You can also reveal the consequences of branch retinal vein occlusion into the retinal arteries. So if you have a look at the central retinal artery here that splits in two, to the left, you have flow throughout the cycle, and here to the right, the flow is very different. The depth, the modulation depth of the flow is different. So we do expect the resistivity index to increase over here, and that's exactly what we have, and not in the other branches. And it has the consequences for vision that ophthalmologists know very well. Okay, that's the same patient. Okay, you can also spot arrhythmia, irregular and premature heartbeat. Here you have an extrasystole, for instance. I'm checking the time. Okay, same patient, irregular heartbeat. And this patient also has had an occlusion. That is the reason why you see tiny vessels over here, winding vessels. And I think it's the last one. It's takehome arteritis. It's a case of hypoperfusion. Two patients, one with a mild form of the pathology, and have a look at the systole with a less steep increase here. And another patient with a more dramatic form of the pathology, where you don't have a triangular pulse wave anymore, but you have something sinusoidal in central retinal artery, which is really not good. Okay, if I have time, I would like to speak about the way we try to valorize this system, because for now, everything that I have presented was made with a very, very fast camera. Do I have time?
Thank you for asking. Yes, of course. You have less than 5 minutes. Is it enough?
Excellent. So okay. I can go up to the take-home message then. Thank you. So we tried to do the same with a much slower camera. So typically here in the last row, you see what the kind of contrasts that we get in different frequency bands with a very fast camera. So typically 75 kilohertz, you get all this range. And with a camera that goes only up to 10 kilohertz, we have typically those two images. But we remarked that this image here at very low frequency that we can reveal by statistical filtering looks like this image here, okay, that we can only get with a very fast camera, but in reverse contrast. So that's exactly what we did. We reversed the contrast of this image and looked if it looked like the image that we get with the fast camera. And yes, pretty much. At the exception that in region where the radiation is typically absorbed, it gives you a false positive, a false signal that could be interpreted as Doppler, and we cannot discriminate. But what we're very pleased with is that we have the proof of concept of making this Doppler measurement with a much slower camera, down to here 8 kilohertz. We see the pulse wave that is typically recorded so with a slow camera. What we do with the fast camera is typically to collect the tails of the Doppler spectrum. So high flow, a large broadening, and we record the tail with the fast camera. And here with the slow camera, we record the inverse of the loss of signal here. And so we've been able to do the proof of concept with 8 kilohertz camera. Here, we still see the arterial pulse in the retina, and we can still make beautiful images like we do with the fast camera. So here are a few references about everything that has been covered in this presentation. And my take-home message will be this interferogram and its fluctuations enable you, through computational imaging, to collect a wealth of information about the eye. Thank you.